central lines here, and I want to show you a little bit about central lines. You will be able to do anything you need to do with central lines, okay? Again, pushing meds through them is okay, but I need you to be aware that the safety stuff is not just for funsies and for nursing school, okay? Especially with a central line. So I'm going to have this here during all the labs so that you can take a look at it and reference it. But what makes it a central line is that the tip of the catheter is somewhere in one of these main veins dumping back into the heart. It's in central circulation, meaning it's going right back to the heart. So it's either has a tip in the subclavian vein, it's got a tip in the jugular vein going back down, or it's got a tip in the vena cava going back to the heart, okay? So if you have a peripheral line or a midline, welcome. If you have a peripheral line or a midline, those are not the tip of the catheter in central circulation. It does not matter where the line starts, okay? The line can start here in your arm. The line can start up here in the chest. The line can start down here in your femoral. But where the tip of the catheter is what makes it a central line. So you can have a line in your arm that is both a peripheral line and a central line. It just depends on the length of the catheter. So let's talk about a couple of different ones, and I have them all on the little table here, and I will let you guys come and play with all these during lab. This is our typical central line, and you can see it's pretty short. Okay. It can have anywhere from 1 to 3 of these lines attached to it, and it is short, so it's usually poked into the patient right there on top of the line. Subclavian, jugular, they're put in right directly into those lines. You can see they're not that much longer, so they have to be poked in pretty close to central circulation. So these are pretty obvious when they're central lines, because they are put in the chest or the neck, and then they're going into central circulation. They can have, like I said, 1 or 3 of these ports, 1, 2, or 3, sometimes even 4, 5. It doesn't matter. What this acts like is like if you have a cord controller behind your TV, where you put all the cords and then put a wrap around it. These are 3 separate IVs that then have like basically a cord wrapped around them. So meds in this IV never touch meds in this IV. Meds in this IV will never touch meds in this IV, okay? It's 3 separate IV channels that have basically a common wrap there. And what you can do when you come to play in lab is you can see that they have different exit points on them, and you might not be able to see this very well from the demo, which is why I bring these things here for you to play with. But if you inject into this line has something called, it has words on it. It says proximal, medial, and distal. Go way back into fundamentals. Where do you think the proximal port is going to come out along here? It'll be earliest along the line, so it's going to come out about here. The medial will come out middle of the line, and distal will come out at the very end of the line, okay? So what we're going to do is we're going to inject a little bit of saline, and you can see this one. I don't know if you can see it popping out. It's coming out right about there, okay? So we're going to shake that down. Can't do this for a real human, but then we're going to do the medial line. And again, if you don't see this again on the video or whatever, I'm going to let these things be here in lab all the time for you to play with. The medial line is going in, and it's coming out right up here. So the proximal one came out here, the medial one comes out here, and then the distal one, will come out, and this is just for demo purposes, will come out at the very tip, right there at the very end. So these all have different exit points on them, and this is, why do you think we do this?
To get medication there faster?
So it doesn't really, yeah, they're all going to come out, when they come out and they drip out, it's just so they don't mix, okay? You're putting them in central circulation, and so when this drips out, blood's whooshing by and taking the med with it. And then when this one drips out, blood's whooshing by. So they don't really mix, okay? So you can use this for incompatible meds that don't get along. You can use a central line for that. There are 3 different lines. So a lot of people have that question, and I like to do that demo. If you want to give a med that really doesn't get along with anything, things like chemotherapy or total parenteral nutrition, things that just have so many things in them that you don't want them to mix, we generally put them through the distal port so that they will never touch a med. Like this one might touch the med as it whooshes by. This one might touch things as they whoosh by, but if it comes out this end, it's going to get taken away, and it's really never going to have any interaction with any of their meds. So that's just a little bit about these. But the important thing about central line, what do you think our biggest complications are with these guys when we put them in? Infection is number 1. We have a direct poke into central circulation. If bacteria get in, where's their next stop? The heart, where it's going to get pumped out to the rest of the body. Central line's high infection risk. What else do you think would be a complication with central lines? Any other thoughts? Kind of the same complications that you would have with a peripheral line. What are your problems when you have a peripheral line?
Redness, swelling, infiltration.
Redness, swelling, infection, or infiltration. These things they're in a vein. These veins are much thicker, much stronger, more diluted. There's more fluid running through them, but they can infiltrate, not as easily as a peripheral line, but they can infiltrate. You'd want to look for swelling around there because that could be a sign that maybe this has infiltrated and fluid is kind of coming out around that line there. Bleeding is another one because you have just punctured into a main vein. If the patient's on a lot of anticoagulants or something, they could bleed from that vein up to the surface. So really redness, infection, number 1. Swelling or infiltration would probably be number 2, and then number 3 would be bleeding. Those would be our big complications with a central line. So this is a standard central line. This is another central line. It's also kind of the same length. This one's called a sheath. You can see the difference in this one though. Ooh. They're about the same length. What's the difference?
Yeah, that one.
This one's super thick. This one's big. These are very narrow. You can give fluid real fast through one of these guys. So these are generally used for giving large volumes of fluid. You'll find in the ED they might put these in just so that we can give large volumes of fluid to the patient because they're so thick and they take large volumes of fluid. I don't have a 20 gauge IV catheter, but if you put a 20 gauge peripheral IV catheter up to one of these, you'll see how much wider this one is and how it can take a lot more fluid. The other thing, they will put these in the cath lab or in areas where they're going to use other IVs. This one's not open here. This is something that is called a Swan-Ganz catheter, a PA catheter, that they might use in an ICU. They might use them in the cardiac cath lab or things like that. The reason these are in is because it's called an introducer as well, because then they can put lines in. So it introduces lines into the thing. So if this was in my neck, they could take this and put another line in there. So they'll use these in the cath lab, they'll put them in down here in the femoral, and they actually use this to introduce the actual equipment that they use to the cath lab, the balloons and all the things that they're doing around in the heart. If we want to put a pacemaker in a patient, a temporary pacemaker that is in the vein, and they'll introduce it right into the heart, they'll put one of these in the neck and introduce the pacer wires. So just if you see something called an introducer or a cordis or a large bore IV, that's what these are. They're sheaths, large bore IVs. They can do 2 things. They can give large volumes of fluid, so sometimes you just see them put in for fluid, and we can put in other lines. So that's, if you see one of these things, just know that they're really, really big, and if you pull them out, if they DC them or discontinue them, they're huge, and they're gonna bleed, because that's a big stick. So if you see one of these on a patient, you're probably only gonna see this part. If you see any of these, and the nurse is like, oh, can you pull that out? We, as nursing students, you can do almost anything with the central line. You may not discontinue central lines, okay? That is a big no-go. The reason being, they will bleed, and we don't want you having to deal with any of that, pulling these out. So you do not pull out any kind of central line. So if you see any of these guys and they are central lines, do you see them? The nurse is like, oh, can you pull out that sheath? No. So don't pull them out, no matter where they are, or come and check with your instructor. Is this a central line? And just double check. You may certainly give meds through them, but I don't want you pulling them out. So there's two different kinds of venous sheaths here I'll let you play with. We have another guy here that's even bigger. It is a very large IV. So all the infection, infiltration, bleeding complications get higher and higher the bigger the IV is. Then we have a couple of other ones over here. This one, they're called, we call them midlines and PICCs. They're really not that much different from the surface than the other guys. Okay, you really can't tell from the surface which one it is. Midline and PICCs, though, generally are inserted in the brachial area or in the upper arm. Okay? What's the difference, do you think? Midline is a kind of IV, and then PICC stands for peripherally inserted central catheter. So, what do you think the difference between a midline and a peripherally inserted central catheter? They both look like this. What's going to be the difference between the two of them?
The PICC line has a longer cap.
The PICC line is longer. Exactly. These are both cut short, so they're not like a great picture. I don't have the full length. A PICC line is going to get inserted here, and it is going to, go all the way. It's a longer catheter and will end in the central circulation. Okay, so if we insert this, that catheter is actually going to end up in here. Okay, even though it's inserted here, the catheter is long enough that it will be here. How do you tell? Documentation and chest x-rays, if you can see them on the chest x-ray. Documentation should be, you're going to have to go and look because you can't tell from the surface whether it ends here, which is a midline. It's ending somewhere mid, it's either put in here and here, but it's not making it all the way into the subclavian. It's a fancy, really good, secure peripheral IV, a midline is. A PICC is a central line, but they look exactly the same from the surface. So hopefully someone who dressed it will write on there PICC or midline so that you can tell, but otherwise you have to go to the documentation and find out if this right arm catheter is a midline or a PICC, and why does it matter?
Infection rate?
Not so much infection rate, it's a good thought.
Different meds that you're giving?
Different meds that you're giving,
Is
definitely.
it more so like antibiotics you're giving for that, or?
So you can give antibiotics or some caustic meds through either one. A midline, because it's longer and it's in a bigger, it's not down in one of these tiny little baby veins on the hands or in the arm. It's in the bigger upper arm veins. They're stronger, they can withstand more, and they last longer. So a midline is put in for long-term IV therapy. A PICC is put in for long-term IV therapy. But a peripherally inserted central catheter that ends in the central vein, much more toxic meds can be given centrally because they're ending in a larger vein with more blood volume, and so we can give something that's toxic, but it's getting diluted in the blood vessels very quickly. So usually the difference between a PICC and a midline is for somebody that just can't keep a peripheral IV. The peripheral IVs keep infiltrating, they've got bad veins, but we want to give them something stronger. It's a better peripheral IV, basically, a midline is. It's about this long, much longer than your regular peripheral IV little catheters. It's a longer IV, and it's put in under ultrasound. They're sure it's in a bigger vein, but it's not in central circulation. So if we put a very toxic med in there, like TPN or chemotherapy or things like that, it will still infiltrate the smaller upper arm vein and ruin it. So midlines are treated like peripheral IVs, okay? A lot of people are like, oh, if it's up here, it's a central line, and I can do whatever we do with a central line. Midlines are peripheral IVs. They're just good peripheral IVs, but they are peripheral IVs nonetheless. So there are some meds like potassium and things that have different rates of flow through a central line than they do through a peripheral line. So you'll have to be checking, with your policies and things like that. But for this, I want you to know midlines are peripheral IVs and should be treated like peripheral IVs. PICCs are central lines and should be treated like central lines. Okay. Yes?
How long can each of them stay in?
So most of these central lines can stay in if they're, that's a good question.
Okay.
And let me kind of, I guess this is a good place to bring it in. There's two different ways we put in central lines. You either poke and go straight into the vein. Those are direct access. And then there is tunneled. Tunneled means it goes through something first before it hits the vein. So they can put in peripheral IVs here, and then it kind of goes through the whole vein system before it hits the central vein. That's considered tunneled. They can poke this standard peripheral IV. They can poke this down here, tunnel it through skin before it actually gets through to the vein. So direct poke central lines, the ones that are just directly poked straight into the central circulation, should only stay in for about a week or so. If they are tunneled through the skin or through a long amount of blood vessels, they can stay in indefinitely if there's no sign of infection. Okay? Why do you think we tunnel things, or why do you think they will tunnel them? What is the benefit of putting in something tunneled through the skin or with a long distance of vein?
It's harder to remove.
Well, one, it's harder to remove. Yes, it's definitely, you can't just pull it out and bleed all over the surface. That's a good thought. But there's another thought of why we tunnel things, or why the doctor will decide to put in a tunneled peripheral IV catheter, or a tunneled central line catheter. What do you think is what's it going to reduce? We have three complications: bleeding, which it will, because you won't be able to pull them out very easily. Infection. Because if you tunnel it through the skin, it's going to hit a lot of white blood cells, and there's going to be a chance for it to attack bacteria before it hits the central line. And the same thing with a PICC, because if bacteria gets in here, it's got to travel away before it gets into central circulation and gets pumped out by the heart. So tunneled catheters and PICCs, there's less of a chance of infection because the bacteria has to go a distance or get through something before it hits central circulation. So tunneled reduce infection, which is why they can stay in longer. Direct pokes into the vein, if we just poke one in the ED and they're throwing in one of those things, direct pokes straight in, they are only good for about a week. The last one that I'm going to show you, and then we'll be done with that, is the port, which you may have seen. And again, this is much more of a hands-on thing, so I'm going to keep these in the lab so you can come and play with them. A port is tunneled. It is a metal piece. You can come play with it. It is a reservoir. It's a metal reservoir with a line coming off of it. And they actually physically will place this reservoir. This is all done surgically. Tunneled catheters and ports are usually put in interventional radiology or in a sterile environment. They're not just done at the bedside, just poked in. Tunneled catheters are placed in a sterile environment so that they can stay in longer. And a port is a surgically placed. This is also considered a tunneled catheter because it's under the skin and it's tunneled through and placed into central circulation. The reason we will use ports, what do you think you've seen ports for? What do you think ports are for?
Cancer patient.
These are usually for intermittent, like chemotherapy, where they're going to need toxic medications pretty frequently, but they don't need to be hooked up to an IV all the time. And it seriously reduces infection because now you don't have anything outside your skin, really. When they're not using the IV, there's nothing showing to get infected. There's nothing exposed to the outside world. Whereas if you have a PICC, those little hubs are always exposed to the outside world. Ports are very much long-term meds, and usually for toxic meds that can't go peripherally. But anyway, the reservoir sits right on top of the rib cage, kind of in the muscle area, and then the line is then tunneled through the skin and then pokes into the central circulation further on. So what I'm going to do is we put his skin back on here, and when the port is not being used, you can't even see that it's there. You have to feel it. You feel it under the skin. And that's what this one is as well, is you would feel it under the skin. You never see the port. This is the only time you're going to see the port. is when you're playing with it in nursing school or if they let you see a port. But ports live under the skin, so you never see them. The only way to get into them, so you can't see them, you can't access them, is that they have to put an access needle in it. And what they'll do is they actually physically will poke through the skin. So if we have your skin, give me your skin, Chester. His name's Chester Chest, it's right there. He's Chester. We're gonna put some skin on top of him, and we have the port here. You physically poke through the skin into the port, okay? So I'm gonna take the skin off. I just wanted to show you that. You are poking through the skin, and the only way you know where you're going is there's some hubs on the top there that you can actually feel the port, and you can feel where you wanna go. You poke through the skin, and you poke through here. Once you poke through the skin, you're not poking into their muscle. You're not poking into anything other than a metal or plastic reservoir. So you can't poke through and damage the patient at all, okay? You're poking into this reservoir, and then they put a central line dressing over it, and it's considered an accessed port because there's a needle now into that port. When the needle is in there, you can pull blood out of it, you can put things into it, and you can put meds into it, and it is a central line. Okay, so an access port is a central line. And when you pull this out, do you think it's going to bleed a lot?
No.
No, because you're not physically hitting a vessel. You're hitting a port, which then goes to a vessel. So they're much safer and easier for patients to keep long term. They can get infected, but much less chance of them getting infected than a direct stick. So I just wanted to show you around the central lines a little bit. I will leave these out on their little mats and put it up over in the practice room, so you can come over and play with those at some point. But thank you for recording.